healthcare is a team sport. And once you set a culture and you continue to drive to that culture and refresh that culture, then the patient care is better.
A lot of the data supports this continuous clinical quality improvement process. As part of physician leadership, we need to continue to develop what happens when, and how does that happen when.
When it comes to cardiovascular care on the organizational level, MedAxiom, an ACC company, understands the challenges your program is facing. Welcome to MedAxiom Heart Talk, the podcast where thought leaders come together for one ultimate goal: to continually transform and optimize cardiovascular care for all. MedAxiom Heart Talk starts now.
I'm Cheryl Toth, host of MedAxiom Heart Talk, and today we're turning our attention toward the challenges and best practices for how hospitals and practices use quality data to talk with physicians about poor outcomes. And here to walk us through these challenges and best practices are today's guests. Dr. Mark Masters is joining us from Jacksonville, Florida, and Dr. Jeff Wescott is calling in from Seattle. I had the pleasure of hearing both of them present on this topic at last fall's CV Transforum. So Dr. Masters, Dr. Wescott, welcome to MedAxiom Heart Talk.
Thank you, Cheryl. We're happy to be here.
It's a pleasure to be here.
So let me start by giving listeners some background about both of you. Dr. Masters is a licensed psychologist and administrator for Baptist Heart Specialists in Jacksonville. He's provided leadership in healthcare for more than 30 years and in cardiology for the past 12 in both private practice and integrated cardiology services. And in addition, Dr. Masters is the founder and CEO of MD Abstract, which offers human abstraction solutions that help medical organizations across the country. And also with us is Jeff Wescott, a practicing interventional cardiologist at the Swedish Heart and Vascular Institute, part of Providence St. Joseph Health, a large health system with 50 hospitals in 7 states. In addition to practicing cardiology, Dr. Wescott is the System Physician Informaticist Cardiology at Providence St. Joseph, and he's had a long career in informatics. Since 1990, he's written software applications for cardiology and also actively participated in a national effort to improve EHR workflow, quality, and interoperability. So after listening to both of your perspectives on this, I walked away thinking about how challenging this is for physician leaders and administrators. So when it comes to addressing procedural complications, what do you guys think? Do you start with data? What's the best first domino? And Dr. Wescott, why don't we start with your perspective on this first? Where do you start?
Well, I would say you start with data first. So what are the problems we're trying to solve? What's a personalized data set that says this person is a good cardiologist, intermediate, poor, risk complications are high, average, or above average. So we really need to have a good, usable data set, because when we come to talk to physicians, as an example, the first thing they want to do is to make the data wrong. Oh, this isn't me. This doesn't accurately reflect what I do. So my vote would be start with good data first.
Great. And Dr. Masters, would you agree with that? What would you have to add?
Well, I think I would kind of our story in Jacksonville really started with having data, but not really having the governance structure set up to deal with the data. And what I would say is that began to create anxiety amongst the physicians. And we really needed some processes in place that the physicians could trust as they really started drilling down into the data. So I think the answer, I agree, is data first, but very quickly you need to work on the governance that is going to help you deal with the data and deal with the physicians about the data.
Well, and I know the two of you talked in your presentation about the dyad-leadership model, and so how do you feel that dyad-leadership model helps? How does it support those inevitably difficult conversations that needs to occur?
I can say from the administrator point of view is that I see the administrative side of that dyad is really supporting the physician effort. the physicians need good information. They need it timely. And that allows them to be able to do this really important work. And so it's really an administrative, supportive mechanism and process to really help the physicians do this work.
So I agree with that, Mark. And I think I would, from a cardiology point of view, say the other important advantage of the dyad is that we need to talk to the C-suite as well. So let's say we get a ranking that our mortality post-PCI is excessively high. That report may come to administration and they may freak out. So they're just so incensed about what's going on and frightened by what's going to appear in the newspaper that they're not helpful in the solution. So having a seasoned administrator that can go back and say, hey, look, this is just 2 extra deaths that occurred this quarter. We've looked into it. Here's our process for improvement. It really can disquiet. It can create an atmosphere where we now can problem solve and not get freaked out about things.
Well, and as you mentioned, Dr. Wescott, talking to the C-suite and teeing up this information, tell us a little bit about at Providence St. Joseph, you created these clinical performance groups and how they look at that information, what they do, and how that relates to the conversations in the upper levels and at the hospital level.
Yeah, so this is a bit of a story, and I it's a story I love to tell because it shows how large organizations can in fact be more personal and more successful in smaller organizations. So we have all of these hospitals that have come together, number one, under the same instance of Epic. So our data set is a common data set, a big deal. So our data is good. We have very powerful data analytics. And we've constructed performance groups. These are ways that we can have ischemic heart disease people, cardiologists, administrators meet, structural heart, cardiovascular surgeons, heart failure. Now we're setting up an imaging group, EP. So these are participants from around the system, from different hospitals that meet regularly, virtually usually once a month, face-to-face once or twice a year. And we talk about what we're doing, how we're doing, what we're doing well, what we aren't doing well, where's the science going, what are our quality measures. We have robust discussions that are very, very helpful. Mm-hmm. And we can then set the standards for the organization.
Well, and you mentioned you have one data set, which is ideal. What does an organization do if they don't have a unified set of data?
Well, they work on getting a unified set of data. So our most recent partners are the St. Joseph's Health people, and they're from Southern California, and we have Covenant Health from Texas. So they're not yet on Epic, and they will be. This is a major effort for us over the next 18 months to make sure they're all on the same platform that we are. So again, then when we have a performance measure, we have clinical decision support that's grounded around quality, like a discharge checklist. Everybody can run the same thing, and we can take our quality measures and do it in part based upon that.
Great. Well, and Dr. Masters, is there something similar in terms of quality improvement process at Baptist Heart Specialist? How does the discussion happen there? How does your data get looked at?
Yeah, so we do have a similar process. We worked with the medical staff and the chief medical officer to create a structured, dependable, reliable, ongoing, continuous quality improvement process. And so what it highlighted immediately was the amount of medicine that is being practiced under cardiology. So we've got the cardiovascular surgery, the interventional, the electrophysiology, structural heart, the general cardiology, all of the diagnostics. I mean, it really gave us pause to look at just the incredible scope that cardiologists cover for a hospital system. But then what we did was we looked at the sources of the data, the registries, et cetera. We put together a reporting structure so that it's physician-led all the way through that process with the administrative support. And it provides for a quarterly report out for the health system to be able to see kind of what's happening in that particular subspecialization in cardiology. And it's worked really well. Dr. Wescott made a really good point in his presentation around the fact that this is based on trust. And so I see this as a fairly risky endeavor in the sense that a really high quality program is going to generate energy and morale and confidence in physicians. And if we don't do this well, it's going to steal from all of that and take away from the morale and really can have some fairly negative impact. So we're very pleased with what has come about as a result of this new structure.
Well, and you raised such a good point about trust. For those listeners out there who are saying, well, God, this would never work in my organization because there is not that trust. What advice do you have for those folks? What can they do?
Well, I tell you, one of the advantages, again, of a larger group is it takes some of the personal, some of the politics that are associated with individual hospitals away, because sometimes that environment gets very polluted. Mm-hmm. And it's very, Joe said that, and Sam said that, and Sally said that, and it becomes, things go off the tracks. So again, I think if there are more adults in the room, it really helps to then guide these conversations. So I think it does take administration that is trustable. Mm-hmm. Okay, so they have to be consistent and fair and have personal ethics and make all of that good. It's leadership 101. Wouldn't you say, Mark? You have to start with that.
I would. And I would also say programs like Dr. Wescott's that have kind of blazed the trail and really set that structure. It helps a system like ours with 4 hospitals. It's a smaller environment, and I think that there's that angst is somewhat helped by the fact that we can point to programs that have put these things in place, and we use that to at least start out with some confidence and some trust that this is working elsewhere, mm-hmm. and now we need to try this here. And I think, Cheryl, that the other piece is just you have to do it. You have to go through the process. You have to try it out and learn from some mistakes. But what I have seen literally happen in our program is that trust has developed with some time and experience, and it's working really well.
Good thoughts, good wisdom from the experience you've each had. I'd like to turn us over to how each of your organizations evaluate complications. So you have these structures in place. How do you evaluate the complications at the physician level or the care team level? Any thoughts you have there for listeners?
Well, I can kick that off. So again, you have to have, which we do, you have to have a methodology to collect complications. So you can certainly do it from registry reporting reports. We all deaths, whether it be surgical deaths or cath lab related deaths, are automatically reviewed each case. And then we do a structured analysis of what happened. What could we have done better? So this is called a POCMA analysis, where you look at the pre-procedural case selection. Was that done correctly? Could we have done it better? The operative procedure itself, could we have done that better? Post-operative care, follow-up care, etc. So it's a structured, stylized way to do that then enables us to present these to M&M conferences. Now, we used to have M&M, mortality and morbidity conferences, years ago. It would be every 6 months. We have them at least once a month. And we try to take certain complications and put them together as a group, and then we have an educational symposium for an hour and a half that's based upon that type of thing. Example, yesterday we had one that had to do with valve failures, prosthetic valve failures with a type of prosthesis. It was a surgical prosthesis put in a few years ago, and we had a few cases. So we used it as an opportunity as cardiologists and surgeons and techs to talk about what are the signs of impending device failure and how do we approach these patients in a very timely fashion.
Well,
this isn't. Go ahead. I'm sorry.
No, I'm saying it sounds like because you've moved up from every 6 months or so to monthly, at least monthly, you're able to take action and push out that education much more quickly, which is good for everybody.
And this is the point, Cheryl. This is not meant to be punitive in any way, shape, or form. This is meant to be educational. What did I learn? Okay, next time I do it, I'm going to do X, Y, Z. Or, you seem to know more about that than me. Come scrub in with me and let's do the next case together.
Mm-hmm. Great. And Dr. Masters, what's happening in your organization? How do you evaluate the complications and how does that process work?
Well, I think that what I would share is the really incredible progress that we've made. When we started out, this was very much this is the methodology. It is a combination of clinical administrative nursing, and the medical directors really scrubbing the patient chart, looking for what happened and looking for the nuances and details. And then working with the physicians in the small groups to go over those details and look at what action plans need to be put in place. So that all started. But what I would say to you is that it's kind of one thing to have that going on and it be kind of a process. Everyone is just doing the process. But what I've seen happen as a result of that is that the physicians put together an M&M conference as well, in addition to that. And now that room is really standing room only. It happens once a month, and there is tremendous energy in that room. It is very much where they have to work out the details of the case, and then those details are presented. It is thoroughly discussed, and physicians are leaving that room with some plans in their mind and some plans on paper as to what they're going to do going forward. Mm-hmm. But I am most impressed. I can tell you from the administrators, I'm just most impressed with the energy in that room. It is a really nice thing to see on behalf of physicians.
Well, to have that energy around education and knowledge and sharing, and I love that you've got standing room only at this point. Everybody's interested, and it's a testimony to where you've led the organization. Now we've talked about the process and the education.
So Cheryl, can I add to that just seconds, because I just thought of that, and Mark is a psychologist, and I would also say part of the reason that there's positive energy in the room is that we as providers, when we have complications, we grieve over those complications. We don't want our patients to have complications. To have an environment where we can freely talk about what we did, how we did it, what our decision-making process was, what our insecurity was about proceeding in the way we did, what we learned from it, that helps to heal us as providers. And we don't have people in our environment that regularly heal us. So to have a group like that works together for common good, i.e. improving quality, is very, very healthy.
So it's interesting that you're talking, Dr. Wescott, about the conversation in that M&M environment. And so I'm curious about let's talk about the conversation that you have one-on-one with cardiologists. Does it start? Do you start with data? Do you start with the one-on-one conversation with the doctors who are, whose procedural complications are at issue? Do you have that in the M&M environment from an education standpoint first? How does that work and who's involved?
Yeah, so the one-on-one would be more for I'd term them problem physicians. They have this chronic behavior that also is associated with poor results, but for whatever reason, they don't seem to improve. Okay, mm-hmm. And I think every organization has had these particular players. So if I'm cath lab manager, cath lab director, I would have a sit-down one-on-one and talk with this person and say, okay, here's the data, here's what we've observed, what do you think about that? Oh, I think the data is all screwed up and I'm perfect, but I don't want to come to your meetings and whatever, right? So if they're not willing to have a project plan to improve themselves, then we've got a problem. Now we have to have a formal process so that this person either changes or goes away. And so that is a medical staff organized peer review process.
Okay.
Now, that's very serious, and it's directed about losing privileges or going away or fixing what you did. So that is the minority of quality improvement, fortunately. Most of us, if we've had these individuals in our organization, they're now gone.
So the majority with it can be handled with this education focus, the sharing, the M&M kind of looking at the data and talking about it so everyone improves. The occasional situation is this one-on-one difficult conversation, part of peer review. And I'd be curious, Dr. Masters, from your perspective, since you have the psychology background, how should organizations best deal with the conversation, how it's handled, and maybe the anxiety that physicians may have about that?
Well, I would say that the organization, from the administrative side, the C-suite side, really need to do a gut check and make sure that they're approaching, quality improvement and dealing with complications from the perspective of quality improvement, and that it's not a punitive type of situation. Because when it is really focused on the quality and the development of additional quality, helping physicians develop their skills, that kind of thing, what's going to happen is the physicians that are, let's say they're defensive, they're just worried. They're not quite able to deal with that defensiveness like they ought to, maybe. They just need a little help. You end up scooping those physicians up in the process, and they relax and they learn how to do this, and they come along. I think of an example right off the bat where, we had an interventionalist, had a complication, was asked to come and present, had never been to any of the meetings, so hadn't attended just voluntarily one of the meetings. So he really had no context for this. And he came in and started out, was very defensive and not sure why he was there, kind of challenging. But he did not go first. So he had the help, maybe the advantage of listening and seeing another physician present their case and go through the process, and great feedback. And by the time he went over his case, he, I think, really kind of relaxed, and he leaned into it. And he did a great job. It ended up being a really thoughtful discussion, and I think very helpful to him.
Always great when there's a happy ending to these kinds of conversations. I know they're never comfortable to have, but they're very important, as for all the reasons you all have mentioned. I think we'll take a break here and come back and talk about some of the sticky issues. We'll continue on some of these sticky and challenging issues. So don't go away. This is MedAxiom Heart Talk, and we're with Dr. Masters and Dr. Wescott. The MedAxiom 2020 annual survey is now open. Submit your data to receive your customized key indicator report. As a MedAxiom member, you'll have the ability to submit your CPT, FTE, and compensation data through MedAccess. MedAxiom members, go to medaxiom.com/annual survey. Not a member yet? Go to medaxiom.com and click the Become a Member button. Complete the short form, and someone from MedAxiom's membership team will be in touch. We're back, and we're talking with Dr. Masters and Dr. Wescott about reviewing quality data and having difficult conversations with physicians about procedural complications. And so I thought we'd move on to some of the, like I said before the break, stickier issues that you both have had to address in your organizations. For example, what do you do about operator skill or error when there's a pattern of complications? How do you approach the discussion? Which one of you would like to take that one?
Well, I think we both deal with this, and this is part of being a dyad, right? So if there's an operator that has a high ongoing complication rate, then again, to have a sit down to say, how can we help you improve what's going on? Let me tell you a bigger issue, though, and this has to do with these kinds of dialogues on an administrative level. So let's say that we found in our system that there were 3 or 4 hospitals whose cardiac surgery volume was low, who had a disproportionate complication rate for cardiac surgery. And this we did.
Mm.
So the key is a certain volume level we all would acknowledge is necessary to do things optimally. So knowing that data and having this very organized group of physicians and administrators, we were able to take those programs out of certain hospitals and coalesce into other hospitals. We would never have been able to do that 5 years ago.
Because
Because
data?
we could do it without making people wrong.
Ah.
Right? The problem, the program isn't working. We've got long-term data. How do we fix it? So let's move to a fix. Does it make it uncomfortable for certain providers? Yes. Is it in the patient's interest long-term? Definitely.
Mm-hmm.
Is it in the institutions, in the enterprise's best interest? Definitely. So we can take some of these little local things and solve them because we have a larger, a higher perspective that isn't just personal.
The greater good, as it were.
The
larger
greater good.
organization. Yeah.
Yep.
And Dr. Masters, how does this work in your organization at Baptist?
Well, so I think that what we try to accomplish here is that let's say that one physician is having an inordinate amount of complications, and so it's that trust and problem solving that would kick in to say, how can we be of help here? And I think that that could be some additional training. It could be some additional resources, equipment. But the key is that in a methodical way, we are constantly trying to improve what's happening, and everyone is willing to address the issues and the complications. And that physician has to be a part of it. So really, the only time that breaks down is if the physician is not willing to participate in that process and take action. And so done well, most of the time that works out. I think at the extreme of that might be, a physician who just technically it's just talent, maybe.
Mm-hmm.
Not necessarily skill, because skills can be learned, but let's just say that it's talent. And what they've done is kind of get into a niche and a subspecialty that doesn't really fit them well. And so this might lead to conversations about how they can adjust what they're doing in their practice of medicine, and how that might play to their strengths and help get them out of a situation where they're really just having a lot of trouble.
Dr. Masters, you used a turn of phrase that I think is really important. You said in that conversation, to build trust, the question, how can we be of help? That's sort of a coaching mindset more than we were talking before the break about this is not punitive, it's not wrong. So I really like that. I imagine that builds trust and better communication with those physicians that need the support. Am I correct?
And I think it really reinforces truly what we're trying to accomplish together as a team and as a group and as a practice, as an organization. So, yeah, I think it does reinforce that. And, it helps a physician really evaluate things carefully. As Dr. Wescott said, these are huge decisions, and these are life-changing decisions sometimes. Mm-hmm. And they need to be made very thoughtfully by everyone involved. And administration having a knee-jerk reaction, like we talked about earlier, is not helpful at that point. We really need to plow into it and be very thoughtful as we move through that process.
Well, you mentioned just now the organization having a knee-jerk reaction, or how that occurs. What is the cultural impact in an organization of these kinds of things, of taking action against a colleague, or just the issue itself and how it's communicated to the provider? What kind of impact at the organizational level have you seen, Dr. Wescott?
Well, it can be devastating, and it depends on how it plays out. So let's say we have a surgeon whose ethics are questionable, who has some complications, and there's a story in the newspaper, and go down that pathway, okay? And it happens. It's rare, but it is so devastating to an organization because there are lawsuits, there's loss of trust, there's loss of image of the organization. Everybody gets, there's CMS investigations, there's all kinds of things. So failure to do this, to what we're talking about, failure to have a quality program that includes everybody and it really does work is critical to avoiding these disasters that institutions periodically have to suffer. So yes, these are devastating events.
And anything you'd like to add to that, Dr. Masters, from your organization's perspective and how you handle that?
Well, I tell you what, I would take the opportunity, Cheryl, to say that, medicine is continuing to evolve. And I think that a lot of the data and data collection supports this continuous clinical quality improvement process. And I think that as part of physician leadership in this area, that we need to continue to develop what happens when, and how does that happen when, and that we're not there yet. I think we are becoming ever more sophisticated in how to approach this process and how to conduct this process. But at the end of that story, if it's a 1% where we need to take action and strong action to protect the public, et cetera, that we're talking about, this evolving more, supporting state medical boards, supporting those kinds of actions, and that we need to press forward so that we use this expertise to help improve this process all the way through.
And are there other contributing factors to patient outcomes and to complications that are not tracked or reported to registry databases that we should talk about?
Oh, a lot. So the registry databases are one part of it. And the good news is it's fairly standardized data, right? But I do think that we need to emphasize the fact that healthcare is a team sport. And there's lots of members to the team. Yes, there are physicians. Yes, there are administrators. But there are people who they register the person. There's the RN community. There's the housekeeping community. There's the parking attendant. I mean, everybody can do a better job. And once you set a culture and you continue to drive to that culture and refresh that culture, then the patient care is better. What is the accessibility of the patient to the institution? How easy is it? Right? So we have so much to learn in medicine and to continue to improve, and all of those are quality measures. What's the cost of drugs? How do we go and help offset the cost of drugs so that we write a prescription, we think somebody's taking a medication, but you know what? They're not. What is our methodology to ensure that they fill a prescription? So we're babies in all of that, but we need to do all of those kinds of close the loop activities in healthcare much, much better.
Yeah, I really agree. Even the registry data is still, not as robust as it needs to be. And so just that report out of that clinical data is needing to be combined with all of the other aspects of care. So as we're holding physicians accountable for outcomes, we must pay attention to everything that affects those outcomes, and including the post-procedural care, the nursing ratios, things that can be very important to the whole entire process. And it's a work in progress for sure.
And Dr. Masters, are there any particular examples you have that you can share in your organization and how you've done that?
Well, I've seen just of late in the surgery program is the medical director of the cardiovascular surgery program has really taken the initiative to evaluate the post-procedural care for the CABG patients. And he has made some changes in how that happens, and the rounding and who's doing what. And it has made a very significant improvement and some of the complications and the level of complication. So again, physician leadership. There isn't any administrator who's going to be able to do that. The physicians are the ones that can really make this happen. So good, quality physician leadership and looking at these kinds of adjustments and changes just make a huge difference. And so he's done a great job in that realm, and we're enjoying the benefit of that.
And Dr. Wescott, anything at Providence St. Joseph that's worked well when it comes to these sorts of changes? What's happened in your organization that you can share?
Well, a simple example, and this is happening everywhere, is same-day discharge for a number of procedures. So it's a win-win-win thing. So let's say I do a stent in somebody. We would typically have kept those folks overnight. We did nationally, we did an analysis review, and it seems that was unnecessary because the event rate was low, and therefore we could discharge patients the same day. And so to have a system then where 4 hours after somebody has an uncomplicated routine stent procedure, they're going home. Now we need to assure that their follow-up medications are at the pharmacy, that they have a driver, that they have a follow-up appointment, and that's all organized. And then we can have that be a quality measure, because you know what? The patients far prefer to go home than they do to stay overnight. And oh, by the way, it saves us $1,500 a case. So it's win-win-win. Now in the EP community, they're sending people routinely home after ICD implants and even after AFib ablation, and now that's become quality measures as well for them. So it's an example of how we can kind of link things together. It's better care, more organized care, less expensive care, so there's a value statement, and the quality is good.
Great example, and patient-focused. And yes, but thinking like the patient, that'd be me. I do want to go home. So all of those things would contribute very positively to my experience. So let me move us toward the exit. Gentlemen, any advice you have for listeners? Dr. Wescott, as a physician, you have a few final pearls of wisdom that you can share today?
Again, my pearls of wisdom would be enjoy this as a team sport and grow all of the players that participate with you. And we've learned a lot through our structural heart program about how we work together, different specialties, different procedures, and everybody's doing it. Let's do it well. Let's celebrate what we're doing well. And again, never, ever lose focus of the fact that it's all patient-oriented.
And Dr. Masters, how about you?
Yeah, I think that, my parting words would just be that I think we need to continue to create and protect some space and time for physicians to be able to focus on this quality improvement process. It brings out the best in the physicians. It is the best thing for the patients, and I think we all benefit. And over the next decade, the cardiology services will improve because of it. So it's a great investment in ourselves to create that space and time for physicians to do this work.
Great. Thank you. Well, that wraps up this episode of MedAxiom Heart Talk. And Dr. Masters, Dr. Wescott, can't thank you enough for joining us today.
You're very welcome. It's been a pleasure.
If you liked today's episode of MedAxiom Heart Talk, please subscribe if you haven't already, and recommend us to a colleague. And review us, please, on Apple Podcasts or wherever you get your podcasts. If you'd like to give us feedback directly or make a suggestion about future guests and topics, send an email to hearttalk@medaxiom.com.